In simple angioplasty, you're using just sort of a certain limited number of guide wires, which are very thin, fine wires, and balloons and stents. For complex angioplasty, there are a whole host of other things that we can possibly do to either give us more information about the artery or to actually treat a very severely diseased artery. So if we go through those bit by bit, firstly, we have a special type of wire that we call a pressure wire that has that has the ability to measure the pressure drop across a narrowing inside a coronary artery. And once we have that wire in place, we infuse a drug into the patient which dilates up the artery, and that maximizes the clinical effect of that narrowing, and that lets us know whether or not that narrowing does need to be treated, both in terms of relieving symptoms and also in terms of the possible prognostic effects. That's to say whether that narrowing is likely to cause problems like a heart attack in the future. So that's a pressure wire, and that is, as I say, just simply a very specialized sort of wire. Then we also have a device that we call a camera. Really, it's a very small ultrasound probe, which is just 1 millimeter in diameter, and we can pass that down the coronary artery, and that gives us an accurate picture of what the inside of the artery looks like, and that can help to quantify the amount of calcification, exactly how narrow the artery is, what the true diameter of the artery is, and that helps in particular when we're deploying stents, putting stents into specific parts of the circulation, especially in what we call the left main stem, which is the beginning of the artery on the left-hand side, which actually ends up supplying about 3/4 of the blood supply to the heart. And we call that intravascular ultrasound, or IVUS for short, and that's an adjunctive therapy which we're able to use. There's another technique that we use as a lot of our patients now are becoming older and often have very calcified and very hard chalky narrowings of their arteries. Sometimes it's not possible to actually initially begin to dilate those arteries with balloons, that there is so much calcium in the wall of the artery that you're not able to actually dilate the artery up. So we have a technique called rotablation or rotational atherectomy, which uses the same principles, where we pass a different sort of specialized wire down the artery, and then we use a device. It's called a drill, but really it's more like a dentist drill. It really just vibrates at about 150,000 revs per minute, and effectively it just it just disobliterates the artery. It sort of almost sort of pulverizes the calcium, makes it into tiny microscopic particles that then get washed out of the artery and reduce the amount of calcification, so that then we're then able to actually take balloons, dilate the artery and put in stents. And so where you had a very restricted, very heavily calcified artery, by getting rid of the calcium, it's almost like turning the clock back, and then you're able to then dilate the artery up. So those are the 3 adjunctive therapies that we use in addition to the ordinary equipment that we would use for a typical angioplasty.